Hello and welcome to Fertility Talks by Kiran IVF. This is a special initiative by Kiran IVF to educate the public about infertility treatments and the causes of infertility in general. You must have all heard of the term demographic dividend. It is basically the economic benefit a country arises from a young population, a young working population. So, for India to keep reaping the benefits of the demographic dividend, the total fertility rate must not decline below the replacement levels. However, recent studies have shown that the total fertility rate in India is on the decline. In fact, India's total fertility rate has dropped from 6.1 in the 1950s to 1.9 in 2021. Which is well below the replacement level of 2.1. Our neighbor China went through the benefits and reaped the benefits of the demographic dividend. In fact, China is going through a decline in their young population, and they are in fact incentivizing people to have more kids, and they have no longer restrictions on one child per family. There may be many socio-economic reasons for the decline in the total fertility rate. But today we are only going to discuss the reasons, the major reason, which is an increase in male and female infertility in India over the last several years. So to discuss that, we have our esteemed panel with us. We start with Dr. Kiran who is the medical director and head of gynecology and infertility. Dr. Kiran is one of the most eminent gynecologists and obstetricians in India. She has been a chairperson of the fetal and genetic wings of FOGSI, which is the Federation of Obstetric and Gynecological Societies of India. And she has also been the vice president of the same body. A gold medalist in her undergraduate and postgraduate programs. She has extensive experience of working in India and abroad. And she was in fact in charge of the fertility department at the Government Medical College and Government Hospital in Hyderabad. Welcome, Dr. Kiran, to our program.
Thank you.
Next on our panel is Dr. Pratima. She's postgraduate and consultant female fertility specialist in Hyderabad. And she's responsible for ovarian stimulation protocols, follicular monitoring, oocyte donor and gestational surrogate program for NICA. She's very passionate about her work and obsessed with following evidence-based protocols to optimize IVF results. Welcome, Dr. Pratima. Good to have you. Dr. Shravanti, fertility consultant, obstetrician and gynecologist at Kiran Infertility Centre, Hyderabad. She has completed her undergraduate and postgraduate studies from Kurnool Medical College and has finished prestigious fellowship in fertility research and has extensive laparoscopic training. Welcome, Dr. Shravanti. Good to have you too. So, as we were discussing, we will start off with, Dr. Pratima. You know that male infertility, in fact, is on the rise. So, what would you suggest men should take precautions to preserve their fertility?
Thank you, Dr. Samit. Yes, as we all know, till now we've always spoken about female infertility being on a rise. But now male infertility is also dominating. And it's become a social stigma for males. To be honest, males are more affected than females because it's actually stressing them out about, not having kids because of male infertility. The social stigma now being attached to it has caused a lot of concerns in the male. So 40 to 50% of infertility that contributes to a couple comes through the male. So now, in the recent past, there's been a lot of research and advances in prevention of male infertility. So whenever a couple comes to you and there is a diagnosis of oligospermia or actinospermia, we should always counsel the male factor and the male to counsel the partner to preserve his fertility. So most important thing now related to male infertility is the lifestyle, scenario which the modern couples are facing. The extreme stress levels that they go through the workplace, the smoking, the alcohol consumption, and especially with lifestyle disorders, obesity, decrease, physical activity contributing a lot to oligospermia and actinospermia. Then there's a lot of history of infections, sexually transmitted diseases, which is quite rampant amongst males, which now has to be prevented. A lot of awareness has to be brought about how you can prevent, sexually transmitted diseases. Again, exposure to a lot of toxins, pesticides, chemicals, in form of environmental toxins that the male, even the females are going through. Then any kind of trauma that the testicles have, had, in the childhood or during the time in the recent history has also to be spoken about, and adequate measures taken there to prevent injury.
So for the benefits of the common public, Dr. Kiran, can you please explain to us the mechanism or the physiology of male sperm production?
Yes. To talk about the physiology of the sperm production, sperms are produced in the male testicular organ, which is called as testis, and both the testes, right and left, are situated in the scrotal sacs, and they are the ones where the production of the sperms takes place. Now, for this whole process to take place, actually there are some hormones being released from the brain, that is called as the follicular stimulating hormone and the luteinizing hormone. And these two hormones actually do the two functions which the testis is supposed to do. First function of the testis is to produce the sperms in the seminiferous tubules. There is a big lining and a big bunch of tubules which lie in both the testes, and this spermatogenesis starts in the boys around the age when they are becoming, coming to puberty. So the age varies from 12-13 years to there onwards. But for this whole apparatus to function properly, we have to go back to the childhood days, or the day the baby is born, the male baby is born. So, what we used to actually teach the undergraduates and everybody there is that please examine both the testes, whether they are in the scrotal sac or not. Sometimes they can be in the inguinal canal, or one of the testes or both the testes could be in the abdomen also, because they are initially abdominal organs in the during the embryogenesis and during the fetal life, and afterwards they come down to the testes afterwards. So this all is the one which the whole process starts from there, and the first sperm cells or the mother sperm cells are called as the spermatogonia, and then they finally form the sperms which come into the ejaculate.
So if a normal, if somebody is planning to get married and he wants to check his fertility, what is the most important single test that you would advise him? And what are the parameters in that test that he should check for?
The single most important test we advise for the male partner or the person who's about to get married or is recently married is a sperm analysis, a proper detailed sperm analysis in a good laboratory where they follow the WHO standards. And the main factors which have to be analyzed by the person who is doing, whether the embryologist or the technician, whoever does the sperm analysis, is to first look at the ejaculate. How much is the quantity of ejaculate, total ejaculate, and whether it is viscous or whether it's normal in consistency, and what is the liquefaction time. After that, they have to see the color and other factors also, and they have to put the semen under the microscope and examine. So according to the WHO guidelines or the standards, there are certain standards set.
So what is the normal expected total count that is to be expected in a fertile male?
Earlier, like we used to tell the patients that it is about 50 million, 60 million, but slowly, that we have come to know the reality, and we have realized that about 15 million sperms in 1 ml of ejaculate, and total number of sperms about 40 million is okay. That is able to, that fecundity is good and they are able to fertilize the egg. And
is only count important, or motility and the form, the morphology of the sperm is also important?
Yeah. Apart from the count, count is of course the absolute thing, but more important also are the other factors like the motility of the spermatozoa. The spermatozoa, if it's not moving fast, that is having a grade 1 motility and going to the egg, it will not be possible to actually do the impregnation of the egg. So the motility at least has to be, the fast moving ones have to be at least 25% or so, and the total motility should be 40 to 45%. We can divide it and, like say grade 1, grade 2, and grade are the ones which are hardly moving or they're just wriggling there. So that is the motility factor is also very important.
Thank you for that. Moving to you, Dr. Shravanti. As Dr. Pratima told us, the precautions you could take and the common environmental and lifestyle causes of male infertility. We all know that male infertility is rising a lot, as we can see that over the last several years we have seen in practical experience also. What are the anatomical or the physiological reasons for male infertility? Not just the lifestyle reasons, the other physiological and anatomical factors. Can you please elaborate on that?
Yes, sure. Coming to male infertility, a number of health issues and medical conditions will affect male fertility. Coming to anatomical causes, undescended testis is the one that is anatomical defect. Usually during the process of fetal development, both the testes will descend from abdomen to the scrotum. So meanwhile, if there is any failure in the descent from abdomen to the scrotum, then we call as undescended testis. So if we can correct it at the right age, then the male infertility will not be there and the sperm production will be good. So the correct age for the surgery of undescended testis is important. And other anatomical issues can be congenital absence of vas. Vas is nothing but the tubule that transport the sperm during the process of this ejaculation. So this vas difference is important for the transport of the sperm. If there is congenital absence, then the sperms will be produced in the testes, but they are not able to get out of it. So that will be the cause for male infertility.
Any hormonal factors that can affect, like high or low testosterone or high FSH and LH hormones?
Yes. So that we can categorize as pre-testicular, testicular and post-testicular factors. So coming to the pre-testicular causes, the main defect will be at the brain itself, that is the production of FSH and LH. So that causes can be congenital or acquired. So congenital causes include idiopathic hypogonadotropic hypogonadism and Kallmann syndrome. So coming to acquired causes, some pituitary tumors producing more prolactin, that is we call as hyperprolactinemia. In such cases, the sperm production will be affected. And pituitary surgeries, previous pituitary surgeries also will affect the hormone production. And any trauma to the head or any radiation to the head will also lead to a decrease in the sperm production due to decrease in FSH and LH hormones. And coming to the testicular factors, here the FSH and LH will be normal or high because the testosterone will not respond to the FSH and LH because the main factor will be in the testis itself. We call as primary testicular failure. This can be due to congenital and acquired causes. Congenital causes include chromosomal defects like Klinefelter syndrome. In a male with Klinefelter syndrome, there are 2 X chromosomes and 1 Y chromosome instead of 1 X and 1 Y. So this leads to abnormal development of male reproductive organs and it leads to male infertility. And coming to acquired causes, most important is infections. Infections or inflammation of the male reproductive system. This can be epididymoarthritis, that means inflammation of epididymis and testis, or certain infections like sexually transmitted infections like gonorrhea, HIV, etc. And certain infections like mumps will cause permanent testicular damage. Even in such cases also, we can retrieve the sperms if you have appropriate protocol and all. And coming to other factors like tumors and cancers of the reproductive system are very important, as the treatment itself, that is a surgery or chemotherapy or radiotherapy, will itself affect the sperm quality and lead to male infertility. And any drugs, the medicines that the patient uses is also important. Certain drugs will affect the male infertility, like cancer medicines, antifungal drugs, and long-term usage of steroids also will affect the male fertility.
Yes, nowadays a lot of young men are going to the gym and taking steroids and they are coming back with azoospermia. So you have to be careful of that. Right? Okay, Shravanti, if a male were to undergo, a vasectomy, which is a sterilization procedure, and suppose, he wants to have a child again, then what are the treatment options for him?
Yeah, if the male already did vasectomy, then we can we should know the appropriate block where at the level of block, like where is the level of block, and the rest of the vas difference, whether it is able to transport the sperm or not. We should check that once, and after that, if it is possible, we can have recanalization surgeries also. or else if it is not possible, we can retrieve the sperms from the testis.
And retrieve the sperm from the testis, and after that you can do the ICSI ART procedure, and that is the most common option now. Earlier, when ICSI was not available, people would go for a reversal, but now because ICSI is available, people go for testicular biopsy and ICSI. Right. Thank you. So, Dr. Kiran, who better than yourself to educate the public about the causes of female infertility? So, can you let us know, the lifestyle reasons and the other medical reasons? A bit in detail, please.
How it goes is actually as soon as the couple walks into your OPD and they are registering at the counter, or they are actually coming to you for the first visit and talking to you, your mind starts thinking about what could be the cause, what is the age she's coming into, whether the husband-wife age group, lot of difference is there or not, and whether from sometimes even from the walk or even from their stature, everything we can little bit start guessing what may be the reason, or they may not be 100% correct, but some girl or some lady who's obese and who has a BMI higher than 30 or 28 like that, so we may actually or has some kind of other stigmata of polycystic ovarian disease, so like that it starts. But finally the causes run into various reasons where we detect them by doing certain kind of tests and certain procedures like ultrasound of the pelvis, that is by a transvaginal route and by an abdominal route. So that is our third eye.
So what are the common conditions you find whenever you're doing 10 patients come to you with infertility on a particular day? What is the most commonest reason you find for female infertility? In India, let's start with
Yeah. Actually, the reasons for the whole couple may be divided 50-50 nowadays. 50% in the male partner, 50% for the female partner.
Specifically to female infertility.
Yeah. Sticking to female infertility, we can divide the causes as the most important cause could be because ovaries are the one which are the main reason.
Yes.
And they are the ones, which are sometimes, not irretrievable also, in the sense that if the eggs are finished, then we have to think of other strategies. Yes. So, in the ovarian reason, we have where actually the number of eggs are decreased. That is called as a low ovarian reserve.
Yes.
And whenever in both the ovaries together you have less than 6 eggs, then we call it as a low ovarian reserve.
This is a very important cause now. And with your experience, you would have seen that over the last 15-20 years, the number of women coming to you with low ovarian reserve is drastically increasing.
Yes.
So what do you think are the common reasons for that?
Yeah, earlier when we started our IVF center about 25 to 30 years back, the commonest reason used to be the tubal factor of female infertility. Like the tubes were affected by tuberculosis, by gonorrhea, by other pelvic inflammatory diseases. And the tube gets blocked. There was no method for us to correct that blockage, and they used to be infertile for a very long time, and it is not at all correctable.
Yes.
So those cases I used to see in the beginning. So now slowly over a course of time, what I am noticing is, the other causes have taken over this inflammatory cause. Because the first IVF baby in the world was also born for tuberculosis and blocked fallopian tubes about 50 years back. So what happens is, nowadays, because of changed lifestyle, because of, certain environmental pollutants in the environment, late marriages, and, other important cause is also endometriosis.
Yeah.
So earlier the girls used to get married at a very early age, 18, 20 like that. So this chance of endometriosis was very less.
Right.
Because the retrograde menstruation which takes place and the blood which gets deposited within the ovaries or below the ovaries that damages the ovaries. So over a long period of time they remain infertile and come first time to us for some treatment at 35 or 36 years of age. Endometriosis is a very important cause, like about 10% of the girls may be affected with that.
How about PCOS? Is that also a common condition nowadays in younger females?
Yeah, the incidence of PCOS also has drastically increased. Earlier used to be 5-10% only, but now some studies are showing that as high as 35 to 50% in younger age group.
Right.
If some girl is around 20-25 and from that age to about 30-32 years of age, the commonest cause in the female partner could be the PCOD. And after the age or even prematurely, they can have a low ovarian reserve,
right,
which is also a very important factor.
Right.
That I am finding it more common nowadays because which is detected by the hormonal test called as anti-Mullerian hormone, AMH, and every patient also knows about her AMH. She comes and tells my AMH is very low. So that is, they already realize that something has happened, stress factor or the environmental factor, or getting married late, or sometimes this lowered ovarian reserve can be hereditary also. Early menopause may set in.
Maybe some genetic.
Yeah, some genetic factor like that, chromosomal.
From the mother to the.
Mother to the daughter, and sometimes if they have some kind of mosaicism in the chromosomes and all, also it can lead. Like a chromosomal abnormality, it can lead to premature ovarian failure.
Thank you. That's very informative. Dr. Pratima, Dr. Kiran was just mentioning about age, and it's important in male infertility as well. But how important is age? Especially when it comes to female infertility or preserving female fertility, how important is age?
Age for a woman, the irony for her ovarian, decline, the age is a major factor. One, it contributes to the low ovarian reserve because, as we know, as the graph, the woman is born with millions of eggs, but in the entire ovulation lifetime, all she loses is around 400 eggs. The rest of the eggs are lost. So when she starts menstruating is since when her egg starts getting used up. And this, to be honest, the fertility is as high as 75% in the early 20s up to 30s. And it rapidly declines to up to, around 30, when she's around 30 is around 75%. That's why they say the younger you marry, the faster is the pregnancy, result. But as she declines, as the age she reaches around 40, the fertility declines to as low as 40%. And at 45, the fertility as low as she's got hardly any chances to conceive. Zero. So that's how the graph just comes down. So eggs are never a woman's best friend, to be honest. And this should be taken into consideration that not just the egg that ages, but even it causes chromosomal anomalies. The aging factor around after 35, there's a massive increase in the abnormality in the baby that she has. The incidence is as high as around 30 to 40%.
You're talking about the baby having some genetic or chromosomal
like a Down syndrome or a chromosomal anomaly with, chromosome 13, 17, which is, has major defects in the baby.
Is it also, if higher maternal age, is that also a reason for recurrent pregnancy loss?
Yes, because of the chromosomal anomaly associated with the egg, the aging that is happening with the egg, the quality that deteriorates drastically. And definitely the chromosomal and the genetic variations that happen in the egg, there is a high chance of abnormality in the baby, and subsequently she will lose the baby.
So because you have a high degree of practical experience, a woman coming to you, say in her 44, 45 years of age, what would you recommend to her? Newly married, sometimes, second marriage, 43, 44 years of age, what treatment would you recommend for them? Would you recommend, try naturally for a certain period of time? Or go in for treatment immediately?
Well, if a woman is married and she's about 35, we should always promote her to have pregnancy at the earliest, without even wasting one cycle, is what she should be advised. Because, as we said, that the loss of the eggs is drastic post 35 years of her age. When she's coming at 45, obviously you have to counsel her to undergo certain treatments where she can boost up her fertility reserve. Now, the latest treatment that we are offering to them is ovarian PRP, ovarian stem cell, which probably, if she's got those stem cells in her ovary, could stimulate and, probably boost up her, egg reserve up to a certain limit. Well, this is also under research, and a lot of documentation and studies have been going on. But yes, at 40, 44, she can well try with ovarian regeneration, ovarian stem cell, and nothing works, then she should be counseled for a ovarian donor site program.
Right.
Because that subsequently would give her a baby which is healthy and which is going to be a normal pregnancy outcome.
Yes. So Dr. Kiran, you mentioned about endometriosis. Can you explain to the general public how endometriosis actually occurs? And what are the treatment options, medical, surgical? And some people talk a lot nowadays about lifestyle modifications for endometriosis. People say do yoga, endometriosis gets cured. Do pranayam. Does that really help, or medication and surgical therapy is very important for endometriosis?
Yeah, good question. Endometriosis, it's a retrograde menstruation. When the girl menstruates, 80 to 90% of the blood comes out through the vagina, and it's the normal menstruation. But they say that about 5 to 10% of the blood goes back into the fallopian tubes also. Like what Dr. Shravanti was saying, that the fallopian tubes are the most important part for the fertilization process of the female partner. So what happens is this blood goes on collecting, and it falls into the behind the uterus, near the ovaries only.
Into the pelvic?
Into the pelvic cavity. Pelvic cavity. So most of the girls who have a good immunity status, that is, they are able to reabsorb, all the macrophages will come and other, this cytokines and all that will absorb the blood, and after 1 week you will see that the whole blood is absorbed.
Yes.
But whenever there is an abnormality in the pelvic structures, like there is a blockage at the level of the cervix, or there is some kind of a congenital abnormality of the uterus, then what happens is this blood collection goes on increasing, and if she hasn't got married for a long time, what happens is no pregnancy has intervened. Endometriosis is an estrogen dependent disease.
Yes.
So whenever progesterone came in during pregnancy for 9 to 10 months, then during lactation again 1 year or 2 years, as it used to happen before, so the incidence of endometriosis was low.
Yes.
But now with the modern lifestyle where the girl is getting educated, marrying late, or delaying her pregnancy because of certain other socio-economic reasons and all that, what has happened is this accumulation becomes a big cyst in the ovary. Usually the prime seat of endometriosis is the ovary only. It can be there in the other parts of the pelvis also, but mostly it will form an ovarian cyst, and these are called as chocolate cyst, in the colloquial language, because they are totally full of chocolate colored blood, altered blood over a course of years. And they will complain of pain during menstruation, pain after menstruation, dyspareunia, that is painful intercourse, and they will have pain during defecation and urination also. So this becomes a very stressful condition and very painful for the lady.
Are there different grades for endometriosis?
Yeah, roughly for the general public, I can say grade 1, 2, 3 like that. So grade 1 will be the minimal disease where there is only peritoneal disease, like some few deposits are there. Are not much clinical symptoms. Only when we do a laparoscopy, that is when we put the laparoscope inside the abdomen, we find something there. So, and that may sometimes some authors say that it doesn't even cause infertility.
Right.
But the grade or the stage 2, what happens is some kind of a chocolate cyst forms within the ovary, which is not bigger than this side, that size, we will say like that. For the common public is, if a cyst is there in your ovary, please be very careful about it. Please go and get it diagnosed by transvaginal ultrasound, because 30% of the cysts detected in the infertile patients, they are not caused by simple follicular cysts, they are caused by endometriotic cysts, and which are going to interfere with her fertility.
So would you say that by grade 1, grade 2, it can be medically managed with minimal medication?
See, it depends, the indication for management are 2 types. Like if the lady has finished her childbearing, we are not talking about that subject. Now here we are talking about infertile subjects. So infertile subjects, if there is some grade stage 1 and all that, may not interfere. But if you see it on laparoscopy, you just cauterize those areas, because those are the areas which are going to become later big ones. Surgical management. Surgical management is actually was the main, the keystone. But slowly, with the advent of IVF, what has happened is the surgical treatments are restricted only to the grade 3 or stage 3 type of disease, where the whole pelvis has become a frozen pelvis. The tubes have lost their, whole architecture. They are bound down to the ovaries like that. And the whole thing has become, a total chaos there.
Like what we call in medical terms, frozen pelvis.
Frozen pelvis, yeah. Correct word for that was a frozen pelvis. So, there also, some people have studies where they said that, okay, frozen pelvis was also there. We aspirated those cysts. We gave her progesterones for a very short time of time, and then they actually stimulated the ovaries, got the eggs, and implanted also. So there are 2 schools of thought, but I would say, like if the disease is mild and moderate, we can actually go for such kind of a thing where we actually aspirate the ovarian cyst, give them some hormones to suppress the endometriosis, and next 1 or 2 cycles you go with the IVF procedure. Another school of thought is that if the disease is very advanced stage, do the laparoscopy, correct the thing, and immediately go. And at the time of laparoscopy also, be very, very careful. The surgeon has to be accompanied by an infertility specialist there. Yeah. Because in a small part of ovary also, we have thousands of eggs.
We want
to preserve the ovarian cortex especially. Yeah. And it's a disease which is outside the cortex. It is a surface disease. So don't go inside the ovary and So that I want to convey to the general public is, whenever you are going for a surgery for endometriosis, please choose a center which is doing the infertility work, so that you are guided by that specialist. That specialist is present, very important, and then that in front of you, you see that the ovarian cortex and ovarian tissue is preserved.
So basically, you're saying that there is hope. Even if you have endometriosis,
Yeah.
there's a good chance you can get pregnancy.
Yes.
Assisted reproduction.
Yeah, that's what, because what Dr. Pratima said was, in a very small part of the ovary also, we have got thousands of eggs. So we can retrieve them and always do a good thing for them.
Yes. So Dr. Shavni, Dr. Kiran had mentioned about blocked fallopian tubes and the first baby who is born, actually being born through IVF because her mother had blocked fallopian tubes. So what is this condition? What is the medical term? What are the causes? How it can be managed? Please brief us on that.
Yes. So regarding blocked tubes, tubes are the most important organs for fertilization to happen, because fertilization mainly takes place in the ampullary part of the tube. So after ovulation, the egg will come into the tube, and the sperm, after insemination, it will come into the tube. Fertilization takes place in the tube. So tube is the most important part. Certain infections like PID, pelvic inflammatory disease, and tuberculosis will cause blockage of the tubes. So PID, usually it can be acute or chronic. Acute, we can come to know the symptoms like fever and any pain abdomen like that. But chronic PID, there are no symptoms, and the patient inside inflammation will happen, and it leads to blockage of the tubes. So in such cases, there will be no symptoms, and we cannot find out the exact cause. So, and the tuberculosis also will lead to blockage of the tubes, and it lead to inflammation. As a result of inflammation, there will be accumulation of fluid inside the tube that we call as hydrosalpinx. Because of hydrosalpinx, the fertilization will not take place in the tube, so leading to infertility. And there will be lot of additions because of inflammatory disease. So the tubal factor we can assess by hysterosalpingogram, that in the form of an X-ray, or sonosalpingogram under ultrasound guidance. So after checking the tubal factor, if there is any block, then nowadays we are offering directly to go for IVF, because the tubal recanalization procedure is needs very much expertise, and there is no hope for the future success of this recanalization procedure. So that's the thing.
So if a female was to come to you with hydrosalpinx and she already knows her tubes are blocked and you're planning for IVF, but on ultrasound you see that there is hydrosalpinx,
Yes.
what would you advise? Just go ahead directly with the IVF, or clip or remove those tubes and then do the IVF?
Proceeding IVF without correcting the hydrosalpinx will give less results, like poor results. So correcting the hydrosalpinx by tubal clipping or salpingectomy can be done, and later on we can proceed for IVF.
Thank you. Yeah, that's very important.
That will reduce the risk of ectopic pregnancy.
Yes.
So Dr. Bellingham, can you please let us know what PCOS is, what is the full form of PCOS, and why it's so important nowadays?
PCOS is polycystic ovarian syndrome, affecting a lot of young women, even teens. When a woman or a young teen walking into your clinic who's obese or very lean, with a lot of hair or on her face, black areas, acanthosis nigrans on the neck, the mother comes and complains that she's just putting on weight rapidly. Her lifestyle is just deteriorating, like she's not able to work out, she's not sleeping well, her sleeping habits have been changed. And this is like a vicious cycle that happens between the ovary and the metabolic cycle. So when the woman comes to you, and an early teenager comes to you with all these symptoms, where the mother or the teenager herself says that I'm not having a regular period, I'm having amenorrhea for more than 3 or 4 months, my cycles are irregular, I have painful periods, I have irregular periods. So don't push it under the carpet and say, okay, it's fine, everything will be fine when she gets to be around 18. This is the time when you correct this disorder, because it will end up in a disease if you do not correct it. So that's called the polycystic ovarian disease syndrome. When she has hypertension, she lands up in infertility, and then she lands up eventually with high cortisol and cholesterol and other metabolic disorder with high insulin resistance. So PCOD is one of the most common ovulation disorder affecting young women and teens in all over the world. So it's a major cause of infertility also. See, amongst the ovulation disorders, one of the major causes of infertility also. So
in your practical experience, how much degree of increase have you seen in the incidence of PCOS in younger women over the last, say, 10 years? Has it increased a lot? And what would you attribute?
Yeah, I mean, 1 in 4
this
is now,
infection?
I mean, a young woman who's, in her teens or in her early 20s or even up to 30s, 1 in 4 is a PCOD. So almost 40%, 40 to 45% is her PCOD. Then chances of is increase as high as 45%. And this is again attributed to the lifestyle changes that the women are undergoing in the recent past. In the last recent 15, 20 years or 2 decades, what has rapidly changes the lifestyle of the woman, especially her dietary habits, her stress, her hormonal imbalance that's happening because of her androgen, being increased in the ovaries. And mostly some women also have the genetic, predisposition to this disease.
Also increased consumption of processed foods,
Yes. And processed drinks. Absolutely. High sugar levels, sitting in one place, not moving around. So the counseling to these women or these young girls that you need to make massive changes in your lifestyle is the need of the hour, because they eventually would land up into anovulation and infertility.
So do all women having PCOS land up with infertility?
Well, again, there is mild, moderate, and severe PCOS. Mild to moderate, PCOS is quite common, and again, doesn't really hamper fertility to a larger extent. These women can be taken care with lifestyle changes and kind of, ovulation induction drugs. But if there is severe PCOD where the AMH levels and FSH-LH ratio is deranged, then these women definitely would want to have, would have to go ahead with an ovarian drilling where, the cysts are punctured via laparoscopy, and then an ovulation induction is induced. And then she has a natural conception through a natural intercourse. So this is something which again depends on her hormonal assays, depends on her scan, depending on how many follicles are seen on the scan, whether she lands up into, being categorized as very severe PCOD, then definitely the treatment modalities would be different.
Right. So we discussed in great detail about the common and not so common reasons of male and female infertility. I think we may have missed out on hypothyroidism.
Yes.
Very common. Anybody wants to discuss that?
Thyroid is a very important endocrinological organ for the female as well as the male. And all the total body functions, right from head to toe, are connected to the thyroid. Your metabolism, your sex hormone production, and the basic metabolic rate, everything actually revolves around the thyroid gland. So whenever the thyroid is not functioning properly, it has a bad effect also on the other hormones of the female, like hyperprolactinemia. It leads to high levels of prolactins also. Whenever you're hypothyroid, you're also becoming anovulatory. That is, although thyroid is not directly connected to the ovulation, but indirectly it leads to lack of ovulation. And whenever the thyroid disease becomes very prevalent also, the endometrial tissue also undergoes damage. The endometrial lining where the baby is going to implant also undergoes problems. And her ovulation is affected, her endometrium is affected. Even if pregnancy occurs also, pregnancy loss also is increased. So in general, for the general public and in the general terms, I would say is the thyroid test is very mandatory. Whenever the female and male partners both come, for the male spermatogenesis also it's compulsory to undergo the test. So thyroid disease, other endocrinal diseases like the growth hormone disease, and other hormones like the adrenal hormones also, the cortisols, all these actually come and influence. So that has to be taken care of.
And
also.
left untreated, then it leads to rise of thyroid antibody
Yeah,
in the blood.
that
Can also cause infertility and miscarriage.
Yeah.
Very informative. Thank you, everybody. Dr. Shravanti, Dr. Kiran, Dr. Pratima. Thank you so much for enlightening us about the common causes of male and female infertility and how it can be corrected and managed. Prevention is very important. So we focused a lot on prevention. So thank you, everybody. We hope to continue show us your support. We hope to continue our fertility talks in the future as well. Get you more interesting topics related to men and women's health, especially related to infertility. Thank you.